Parkinson disease is one of the most common neurodegenerative condition. It is the second most common neurodegenerative disorder. So you are likely to encounter it in whatever specialty you do. So it is good to be aware of the disease. I'm going to talk about the diagnosis and the treatment. I would like a little bit of interaction. People on Zoom also can join, and people here, I definitely want a response from you. Let us start with the multiple choice question. So show of hands, it's a true false MCQ. First question, rigidity is the core feature of Parkinsonism. True? False? God only knows. Right. Okay. Question number 2. Idiopathic Parkinson disease is typically symmetrical. True? False? I don't know. I don't care. Right. Okay. Third question, ataxia occurs in idiopathic Parkinson disease. True? False? I don't know. You have to vote for one. And fourth question, D. Pramipexole is a dopamine receptor agonist. True? False? I don't know. And final one, Wilson's disease causes young onset Parkinsonism. True? False? Don't know. That's all right. So now I'm going to show the same multiple choice question at the end of the lecture. And if you have learned something from the lecture, then you will be able to answer all 5 questions. So pay attention. And here we go. Right. So Parkinson's disease is a movement disorder. And how do we classify movement disorders? We classify into 2 broad categories. Very easy. Reduced movements or increased movements. So reduced movements are called hypokinetic syndromes. Hypokinesia means movement. Hypo means less. So it is also called akinetic-rigid syndromes, hypokinetic disorders. Then we have the hyperkinetic disorder. That means increased movement. Hyperkinesia. Kinesia is movement. Hyper means increased. That is also known with the other term dyskinesias. So if you take the hypokinetic disorder, there are 3 main categories. Idiopathic Parkinson's disease, atypical Parkinsonian syndromes, and secondary Parkinsonism. Those are the only 3 we are concerned with. Now, idiopathic Parkinson disease, we commonly use the term Parkinson disease. So when we say Parkinson disease, we actually mean idiopathic Parkinson disease. Now, under hyperkinetic disorders, we have 5 categories. They are tremor, chorea, dystonia, tics, and myoclonus. Now, today's lecture is focused on the hypokinetic disorder, and in that also Parkinson disease. I will make mention of the other 2 just for you to differentiate. So let's go on to the hypokinetic syndromes or the akinetic-rigid syndromes, which I told you are 3. And of the 3, we are going to focus on Parkinson disease. So when I say Parkinson disease, I mean idiopathic Parkinson disease, different from atypical Parkinsonian syndromes and different from secondary Parkinson's. Now, a little bit of history. Parkinson disease was described by James Parkinson over 200 years ago in 1870. He made a beautiful description on 6 patients. He called it paralysis agitans. It was named as Parkinson disease by Charcot. Many centuries later, Charcot gave credit to James Parkinson for describing that. And since then, we use the term Parkinson disease for the disease and Parkinsonism as we go along. So let's talk about Parkinson disease. How do we diagnose Parkinson disease? There are 2 steps. Now we have the akinetic-rigid syndrome. I told you there are 3: Parkinson disease, atypical Parkinsonian syndrome, and secondary Parkinsonism. All 3 of them have what is called Parkinsonism. And that is our first step in diagnosis. We have to first establish the presence of Parkinsonism. Once you establish the presence of Parkinsonism, it can be one of those 3. So the step number 2 is to differentiate between those 3. Is it idiopathic Parkinson disease? Is it atypical Parkinsonian syndrome? Or is it secondary Parkinson? So just 2 steps, very easy. Let's go through them. Step number 1, diagnosis of Parkinsonism. Are there any investigations for that? Unfortunately, no. It is entirely clinical. So we diagnose Parkinsonism using our clinical skills. There are three cardinal features which we can use a mnemonic called ART. It's an art to diagnose Parkinsonism. A for akinesia. Kinesia, I told you, is movement. So when you say akinesia, no movement. That can't be. So it has to be bradykinesia. Brady means reduced movements. Brady is reduced, like bradycardia. It is bradykinesia. R is for rigidity and T is for tremor. So if you remember the art, you will remember the art of diagnosing Parkinsonism. Now we don't use B there because then art becomes Brit. So we use art, A, right? Then the next thing is to know that what is Parkinsonism. Parkinsonism is bradykinesia plus either rigidity or tremor or both. So the core feature is bradykinesia. So you cannot diagnose Parkinsonism without bradykinesia. Bradykinesia is essential. So if you remember the multiple choice question, the core feature of Parkinsonism is bradykinesia. So without bradykinesia, you cannot diagnose Parkinsonism. Okay. So when we say Parkinsonism, it is bradykinesia either with tremor or rigidity. Now let's look at, now no point knowing these terms if you cannot recognize it in your patient. So let's look at some videos. This is a very short video. We have asked the patient to move his hands and you will notice, you have to tell me which hand the bradykinesia is, right hand or left hand. Right or left? Right or left? Left. Watch again, watch carefully. You see, but you do not observe. So observe carefully. Which hand? Bradykinesia. It's a very short video. Right. I will tell you, it is in both hands, but more on the left side. Okay. Now, what is bradykinesia? Bradykinesia is not slowness of movement. Slowness of movement when you move slowly, that is hypothyroidism. You need a thyroxine infusion if you are moving slowly. No, it is not hypothyroidism. Bradykinesia is a progressive decay in repetitive motor action. Example, if I ask the patient to do that, now if we do that from the very beginning, we are doing that. But in the patient, he will start off very well, then it becomes progressively slower. It becomes that. If you ask the patient to open and close the hand, he will start very well, then it becomes like that. If you ask the patient to do that, he will start off very well, then with repetitive movement, it becomes lower in amplitude. So it's a progressive decay in repetitive motor action. So it is not complete slowness of movement. It is a progressive decay. It's a breakdown. Now watch that video once again. You will see the bradykinesia in the left hand more than the right hand. So he starts off well, then it becomes less. You will also note that the patient is not blinking. So he has a masked faces. So one last time, watch the video. You see he starts off well, then it becomes less. And he has a masked faces. Let's move to rigidity. How do we test rigidity? We do supination, pronation, flexion, extension of the arm. You can see the lady doing that on the left arm. And to make rigidity more, you ask the patient to do something with the other arm, a movement with the other arm, and you can see when she moves the other arm, how difficult it is to make that movement. Okay. Now she's trying to flex the limb. With great difficulty, she's flexing it. That is rigidity. So muscle tone, we can't teach you with a video, that you have to feel for yourself, but it only can be demonstrated. So, and next we come into the tremor. Now tremor at rest in Parkinsonism, it is tremor at rest. What do you mean by rest? Rest means with gravity eliminated. Now you don't need to take your patient to the moon to eliminate gravity. All you do is to keep his arms rested on his lap, so that you have gravity eliminated. That is what we mean by at rest. So watch that video and tell me which hand do you see the tremor, which we call a resting tremor. Which hand? Right or left? Right or left? Can't hear. Wakey. Both hands, more on which side? right side. So it is bilateral and asymmetrical. Is it only in the hands? It is a typical pill rolling tremor, meaning as if he's rolling a pill between the thumb and the index finger. Watch this. It's a pill rolling tremor. Pill rolling. It is a slow tremor. A fast tremor is that. This is a pill rolling slow tremor. About 1 to 4 hertz, as if rolling a pill between the thumb and the index finger. It is bilateral, it is asymmetrical. If you're observant, you will also notice that there is a tremor in the right lower limb more than the left lower limb. So it is not only the hand. Watch that once more. So you see a pill rolling tremor beautifully, more in the right than the left. You can see also the right lower limb more than the left lower limb. So that's a bilateral, asymmetrical, slow tremor. Okay, so these are the characteristic features. So you can't make a mistake with Parkinsonism. So Parkinsonism is bradykinesia with either tremor or rigidity or both of those. So the core feature is bradykinesia. So that's what you have to demonstrate first. Right. So step number 2. Now we can recognize Parkinsonism. Our next step is to recognize, is this Parkinson disease or is this the atypical Parkinsonian syndrome or secondary Parkinson's? So what are the, now we are going to work out Parkinson disease. What are the features of Parkinson's disease? It usually affects older people in the 5th and 6th decade of life or older. Males are slightly more affected than females. It's majority are sporadic because patients will come and ask you, will my child get it? You know, is it hereditary? So the great majority are sporadic, only about 10% there is a known gene mutation. Now, what are the typical features of idiopathic Parkinson disease? You have Parkinsonism, and remember these 3. Like a mantra, then you will diagnose Parkinson disease very easy. There's a unilateral onset. It always starts on one side. Then it spreads to the other side and it becomes bilateral. But even though it spreads to the other side, it will always remain asymmetrical. More on the side it starts. So it depends on when you see the patient. If you see the patient at the very beginning, you will see unilateral clinical features. If you see the patient a little later, you will see bilateral features, but it is always asymmetrical, more on one side. So there is persistent asymmetry even in later disease. And the main problem in Parkinson disease is a depletion of dopamine in the brain. Dopamine is a neurotransmitter. There is a deficiency of dopamine in the brain. So replacement of dopamine in the brain gives an excellent response, even in advanced disease. Even though it may be, the response may be short, but there still is a dramatic response. Patient says, when I take the dopamine, I'm very much better. Right? So there is excellent response. So those are the 3 characteristic features of idiopathic Parkinson disease. Unilateral onset, persistent asymmetry, and excellent response to levodopa, which is the dopamine replacement that we give. That's one other feature. For us to diagnose Parkinson disease, we have to rule out what are called red flags and exclusion criteria. So what are these red flags? So we will go through. Red flags are danger flags. When we wave a red flag, it is a danger flag. Persistent symmetrical Parkinsonism. I told you Parkinson disease is asymmetrical. So if you have symmetrical, then it is not idiopathic Parkinson. If there's a poor response to levodopa, we know that levodopa, I told you, it's the dopamine deficiency. They have an excellent response. So if there's no response, then recurrent instability or falls within the first 3 years. Now, Parkinson disease patients do fall, but the falls are later in the disease, not at the very onset of the disease. When people develop Parkinson disease, they don't fall. They fall several years after the disease advances, not at the very beginning. So if they're falling early, it is not idiopathic Parkinson. It is probably an atypical Parkinsonian syndrome. The problem is with the extrapyramidal system, not the pyramidal or the cerebellar system. So you're not going to find pyramidal signs. You're not going to find cerebellar signs like ataxia. If you remember the MCQ, ataxia is a feature of Parkinson disease. No, it is not. Because you don't get cerebellar signs in Parkinson disease. Severe autonomic failure does not occur in the early phase of Parkinson. It may occur in the late disease, but not in early disease. If it occurs early in the disease, then it is an atypical Parkinsonian syndrome rather than Parkinson disease. Vertical gaze palsy. Now in Parkinson disease, we routinely look for eye movements, up, down, sideways. Because if there is, when you ask the patient to look up, he's not looking up. You ask him to look down, he's not looking down. That is a vertical gaze palsy. That occurs in atypical Parkinsonian syndrome, not in Parkinson disease. If Parkinsonism is restricted to the lower limbs, where the patient now in Parkinsonism, I showed you the Bradykinesia, I showed you the rigidity, I showed you the tremor. It is predominantly in the upper limbs and it can affect the lower limbs. But if a patient's upper limbs and face are all normal, they are not hypomimetic, they are nice, but their lower limbs are not moving. They are stuck to the floor. They have Parkinsonism below their waist. That is not Parkinson disease. Okay. That is vascular Parkinson's. Absence of non-motor features of Parkinson disease for more than 5 years. This Parkinson disease is going, but there are no non-motor features. What are these non-motor features? Hyposmia, loss of smell. Now, if you have loss of smell, now you will think COVID, right? But before COVID was Parkinson disease where you have loss of smell. Autonomic symptoms. Patients have constipation, urinary urgency, drooling of saliva, sweating, seborrhea. Sleep dysfunctions like sleep fragmentation. These are all features of Parkinson disease. These are non-motor features of Parkinson, which may precede Parkinson disease. Now, sometimes when patients come with Parkinson disease, we see several years earlier, they have had loss of smell. They have had these sleep problems. They have had autonomic symptoms, right? But autonomic symptoms, not like, not severe autonomic features, but these occur several years. The autonomic features occur later in Parkinson's disease. Sleep dysfunction, like excessive daytime somnolence, right? REM sleep behavior disorders. REM sleep means you are acting out your sleep, dreams. So people are, thrashing about in their sleep. Psychiatric manifestation like depression and anxiety. So this non-motor manifestation of PD usually develops as PD goes on, but within the first 5 years of disease. What are these other features of Parkinson's disease? One is the typical gait. When the patient walks into our consultation, we know the patient has Parkinson's disease because they have this impaired arm swing. That is because of rigidity. And I told you it's asymmetrical, so you get one arm is not moving because there's severe rigidity on one side. Short steps, they have Festinan gait, so they will walk like that. Short steps. And sometimes they have short steps and they have longer steps, longer strides. Okay. That is called Festinan gait. Turning en bloc, we will turn in one movement, but they have to take several steps to turn. Ignition failure, I will show you that in a video. And freezing, they are walking, suddenly they get stuck in the middle. Not a pleasant thing, suddenly you get stuck. Imagine crossing the road on a yellow line. Now it's a white line. A bus is coming and suddenly you get stuck. Right? Then Parkinson's disease gets cured. Right? So that's a problem. Okay, so let's look at the impaired arm swing. Now, can you see that? So there are only two situations where you have an impaired arm swing. One is if you have Parkinson's disease. Other is if you're carrying a gun. On that side, then your arm won't move because you want to pull the gun out. If you look Putin never moves his arm because he's a former KGB agent. So he's trained to have a gun on a side, right? So if you watch this video again, you can see that. Okay, so beautiful swing on the left side, but on the right arm, but on the left arm, he's rigid, so he doesn't move. Now, this is the typical Parkinsonian gait. So look at this gentleman. He's asked to walk. You can see the short steps. Now he's walking normally, right? So he walks. Then you ask him to turn. Now, anyone would turn with one swing. Now, look at this gentleman. He has to take several steps to turn. That is called turning en bloc. So his whole body is turning around with him. So several tiny steps to make one turn. Can you see that? So that is turning. You have to examine all this. Then he's walking. Now he's asked to walk. That is called ignition failure. You ask him to walk, he can't take off. He's stuck to the floor, also known as a magnetic gait. Now he's still trying to walk, he's not taking off. Ignition failure, no start. Then he takes off and then longer starts. Okay. So that is the typical Parkinson's gait. Right, so there are other features of Parkinson's disease, idiopathic Parkinson's disease. So I told you the features in terms of gait, arm swing. Now, what are the other features? Like facial hypomimia, masked face. When do you commonly see facial hypomimia? Usually at exams, at vivas. When you go to the viva, you look at the examiner, you see facial hypomimia. The eyes don't blink. He will keep staring at you, whatever you say. Right? Where do you see hypophonia? Hypophonia is very soft voice. That also again at the examiner. The candidate now looks at the face and the voice becomes very soft. So that is hypophonia. So both you see at exams. The stoop posture, you have the what is called the stoop posture because the flexor muscles are stronger than the extensor muscles. So they have this simian posture. And micrographia. Again, you see at exams that answer scripts. Very tiny, tiny, tiny handwriting. To the examiners, we have to mark this paper so we do know what it feels like. Now look at this gentleman. Who is this man? Muhammad Ali, very expressive man. And then see what happens to his face over time. There is loss of all that expression. He's a very expressive man who has developed facial hypomimia. And micrographia. Now actually I lied. I told you medical students write small letters. That is not micrographia. Micrographia is just like bradykinesia. It starts with large letters, then it becomes smaller. Progressively smaller. Like bradykinesia, I told you, it's a progressive decay in repetitive mode action. Just like that, the handwriting also becomes small and small. Okay. So can you see? You start off, you can read the Ravi, that name Chandra Kuja, then you go to the corner, it's just a scribble. That occurs at lectures. People start writing like you're writing now, and then it becomes a straight line. Dead. It goes beep, 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 like that. Right? That happens to me at lectures when I fall asleep. It's just a straight line in my notes. Okay. Right. So to summarize, Parkinson's disease diagnosis, you know how to diagnose Parkinsonism. Once you diagnose Parkinsonism, you have to demonstrate there is unilateral onset. You have to detect this persistent asymmetry and excellent response to levodopa, and absence of red flags and exclusion criteria, which I highlighted to you. Right. Now we are going to talk just 2 slides on atypical Parkinsonian syndromes and secondary Parkinsonism, just to tell you how to differentiate. Now I have told you how to diagnose Parkinson's disease. Right. Atypical Parkinsonian syndromes are also known as Parkinsonism plus syndromes. That means you have Parkinsonism, just like Parkinson's disease. But there's something more neurological. That is why it's called Parkinsonism plus something else. What is this something else? If you have Parkinsonism plus autonomic dysfunction and cerebellar signs, then it is called multiple system atrophy. Right? If you have Parkinsonism with early postural instability, patient coming with Parkinsonism saying, doctor, from the day we notice that he's falling forwards, backwards, sideways, and vertical gaze pulse. You look at the eye signs and the eyes don't move. They move this way, but they don't move vertically. So vertical gaze palsy, that is progressive supranuclear palsy, also known as PSP. So MSA and PSP. And here in this atypical Parkinsonian syndromes, the problem is not with dopamine deficiency. So they do not respond to levodopa replacement. Unlike Parkinson's disease, which have a dramatic response, you give the patient with Parkinson's disease levodopa, next visit the patient is very expressive. Now I remember in England when I gave a patient with Parkinson's disease, next day he comes to the consultation and say, doctor, I feel like a different man. I'm a new man today. In Sri Lanka, that doesn't happen because people are not like expressive like that. I gave the same patient in Sri Lanka, I gave the levodopa, they come next day and I'm thrilled to see them because the patient is completely different. So yes, අද කොහොමද? මගේ ඇඟිල්ල හිරි වැටිලා. So, you know, that's full option. You have to treat everything, right? They don't want to, because that may be a cultural thing. Because if you say good, so you shouldn't say you're good. When you ask people here, how are you? They say, not bad. They don't say you're good, not bad. So like that. Secondary Parkinsonism, very important that you remember this. Medication, drugs are the biggest culprit of secondary Parkinsonism. So neuroleptics, so as for a psychiatric history, neuroleptics, anti-emetics like metoclopramide, calcium channel blockers. For migraine, some people give flunarizine. For flunarizine, you get Parkinsonism, so watch out for that. Vascular, if you have ischemia, infarcts in the brain, in the region of the basal ganglia, you will get Parkinson's. Metabolic causes, toxic causes. Wilson disease in any young person. Wilson disease is a treatable condition. It's a copper deposition. So it is treatable. So please, you have to diagnose Wilson disease in any patient who has Parkinsonism below the age of 45. So young onset Parkinsonism, never ever forget Wilson's disease. CNS infection like encephalitis, especially Japanese encephalitis, you get Parkinson's. Structural brain lesion like normal pressure hydrocephalus, they presented Parkinson's. So that's the list of secondary Parkinson's. Now we are just going to go very briefly on treatment. Before I go on treatment, just one quiz. This is Vandrume, Mucuna pruriens, which is used by our Ayurvedic colleagues to treat Parkinson's disease. Can someone tell me what is the ingredient? There's only one correct answer there. Multiple choice question, but single best response. Vandrume. Does it have dopamine, levodopa, tyrosine, phenylalanine, or homovanillic acid? Anyone? Any guesses? It has levodopa, 3 to 6%. Those seeds there you see, Vandrume, that is the plant, and from that you get the plant and they make a powder of it and they drink it. So that has levodopa. Right, just to understand the treatment of Parkinson's disease, what you have to understand, what I have highlighted there in yellow is the problem in Parkinson's disease is a depletion of dopamine. It is a deficiency of dopamine in the brain. So here, if you look at the dopamine pathway, it is the amino acid tyrosine, which is converted to levodopa, levodopa to dopamine, and then dopamine is released from this presynaptic neuron into the synaptic cleft, where it binds to the dopamine receptors that you can see down there. Now, the whole strategies, all the strategies in Parkinson's disease is to increase the concentration of dopamine because dopamine is depleted in the brain. So you want to either replace it or maintain it, sustain it as long as possible. So all the strategies are for that. So let's go through that. How can we replace dopamine? We use dopamine replacement in terms of what we call levodopa. So combine levodopa with carbidopa, levodopa with benzotrexide. Right? We can't give patients dopamine. Why can't we give dopamine? Because dopamine does not cross the blood-brain barrier. So we can't give dopamine. We give levodopa, which is the precursor of dopamine. Now, levodopa also is metabolized in the periphery. So that's why we combine it with either carbidopa or benzotrexide, which are peripheral decarboxylase inhibitors. They prevent the levodopa from being broken down before they cross the blood-brain barrier. And Cinnamate, Syndopa, Medopa, those are the trade names. Then we have the dopamine agonists down there, where there are dopamine receptor agonists, synthetic products that will bind the dopamine receptor and mimic the action of dopamine. Those are ropinirole and pramipexole. So the dopamine agonists are, what is available in this country is ropinirole and pramipexole. So you remember the multiple choice question? Pramipexole is a dopamine receptor agonist. Monoamine oxidase B inhibitors. You saw in that pathway, monoamine oxidase is the one that breaks down dopamine. So if you inhibit monoamine oxidase in the presynaptic cleft, you maintain the dopamine levels. So we use monoamine oxidase B inhibitors like rasagiline, salicyline, both of which are available in this country. Rasagiline, of course, is not, I think, registered, but salicyline is registered. In the synaptic cleft, you can see that dopamine is broken down by catechol O methyltransferase enzyme. So we have catechol O methyltransferase inhibitors like entacapone. which can prolong the action of dopamine in the synaptic cleft. Then we use anticholinergics like benzhexol, which, because there is an imbalance between the amount of acetylcholine and the dopamine in the brain when there's dopamine depletion. That has nothing to do with the dopamine pathway or keeping the dopamine, but that is just to make up the imbalance. Then we have the antiviral amantadine. Again, amantadine, you can see down there, it prevents the reuptake of dopamine. Now, with all these drugs, how do we use them? So what I'm going to give you is only the principles of treatment, because we cannot go through each individual treatment. So few considerations. First and foremost is that the treatment is only symptomatic. None of these medications are disease modifying. They do not change the course of the disease. With time, the disease will increase because this is a progressive disease. Levodopa remains the most effective symptomatic treatment. I told you levodopa is the precursor to dopamine. And that whole list, the most effective treatment is levodopa. Whatever you do, whether you give levodopa, whether you don't give levodopa, whether you give dopamine agonist, 50% of patients will develop motor fluctuation 5 years down the line. Whether you treat or not treat, they will develop motor fluctuation. Right? Motor fluctuation means, now initially when you give the levodopa, they act for about 6 to 8 hours. As time goes by, they act only for 2 hours. So there's end of dose problems. Then when you give the dose, they have dyskinesia, they develop chorea. Without the medication also, they develop chorea. So these are motor fluctuation. And majority of patients, 50% will develop it at least by 5 years. Delaying the levodopa does not delay motor fluctuation, so there's no gain in delaying treatment. Then there are non-motor manifestations of Parkinson's disease. They are not dopamine dependent. So patients may develop depression, they may develop constipation, like I told you. Now those things have to be treated on their own merits. For example, for depression, we will use SSRIs. Patients who have dystonia, we use Botox. Patients who have constipation, we use laxative or probiotics, like that. Patients who have sleep problems, we use clonazepam or modafinil. Patients who have walking difficulty, we use rivastigmine. Patients who develop hallucinations, we use rivastigmine. Right, to continue. You can either start levodopa or dopamine agonist in patients. Usually in younger patients, we will start with dopamine agonist. Older patients, we start with levodopa. Very important to start at a low dose and gradually titrate up, because all these medications have a lot of adverse effects, and the adverse effects are nausea, vomiting, postural hypotension, and hallucination. Patients won't tell you about hallucinations, so please ask, do you see someone else in the room when there's no one else there? Do you see little children running around? Do you see animals coming to attack you? And they will say yes, to the surprise of the rest of the family members, because they don't volunteer it unless you ask. Parkinson drugs can be combined. So we sometimes combine levodopa with dopamine agonist or levodopa with the other classes of drugs that I showed. Monoamine oxidase B inhibitors may be used in early PD or motor fluctuation, but they are not as effective as levodopa, as I told you. Catechol-methyltransferase inhibitors are used when the duration of the action of the drugs becomes shorter and shorter. To prolong it, we use drugs like entacapone. Anticholinergics are very useful in tremor. But the problem with anticholinergics, they cause dry mouth, they cause hallucinations. So it's not very useful in elderly patients because they have hallucinations and confusion. Amantadine is we use it exclusively for dyskinesias. We don't use it for treatment of Parkinson's disease. Then there are newer modalities of therapy, which I'm not going to talk to you about, but just to mention that there is deep brain stimulation, duodenal levodopa, and apomorphine pumps, which is not practiced here in Sri Lanka. So in summary, ladies and gentlemen, Parkinson's disease is a progressive neurodegenerative disease, meaning with time it gets worse. The diagnosis remains clinical, so your clinical skills are absolutely essential to make this diagnosis, to recognize the disease. To date, there are no drugs that can modify the course of the disease. We do not have disease-modifying drugs. However, we have many drugs that are very useful symptomatically, so that we can get the patient back to almost normal quality of life by properly adjusting the medication, and that needs to be adjusted with time. So to end, we come back to our multiple choice question and see how many of you have been paying attention. So let's go through it. A, rigidity is the core feature of Parkinsonism. True? False? Yeah, the correct answer is false because the core feature is bradykinesia. B, idiopathic Parkinson disease is typically symmetrical. True? False? Yes, it is asymmetrical. C, ataxia occurs in idiopathic Parkinson disease. True? False? Yes, you don't get cerebellar signs in Parkinson disease. Pramipexole is a dopamine receptor agonist. True? False? Yes, pramipexole and ropinirole are the dopamine agonist. Finally, Wilson's disease causes young onset Parkinsonism. True? False? Very good. So everybody's paid attention. Thank you very much.
Thank you very much, Professor Thashi Chang, for that excellent talk on Parkinson's disease. I think Professor Thashi will be happy to answer any questions that you have. Thashi, you mentioned this is a progressive disease, life-limiting disease. What's the normal duration they live usually?
It is believed that the duration, their lifespans are less than other people because they have other complications like aspiration, pneumonia and all, because they are swallowing. They develop swallowing difficulties, and with swallowing difficulties, they are more prone to aspiration and other complications. So the lifespan is shorter, but not too shorter. They usually live many decades with the disease.
Any chance that we have any cure for this disease in the research?
Parkinson disease, like I said, is the second most common neurodegenerative condition after Alzheimer's. And there's extensive research going on. But unfortunately, today, there is no disease-modifying agent as yet. But there is quite intense research that is happening at the moment. That has been tried, but not with very much success to be recommended universally. There again, now deep brain stimulation is for symptomatic treatment of tremors and motor fluctuations, but not to change the disease course. So it is not disease modifying. I think a couple were done, but now not yet. Universally, there is good response. A properly selected patient, and we are trying to, again in Colombo, trying to revive the place for deep brain stimulation. We have now good neurosurgeons, so we should be able to do that. What is prohibitive is the cost of the. Yeah, benzhexol I just mentioned to you, benzhexol or Artane is good for tremor. It doesn't change, it has nothing to do with the dopamine pathway. The problem with benzhexol is it can cause confusion and hallucination. So in elderly patients, you will be very cautious in adding benzhexol. Also, there is evidence mounting saying that using benzhexol predisposes to dementia. And in Parkinson's disease, later in Parkinson's disease, they develop dementia. So you don't want to push them towards loss of cognitive functions. So elderly patients, I think it's not a good thing to add benzhexol unless you are closely monitoring it. But as younger patients, you definitely can use benzhexol where tremor is a problem. You can get Parkinson's disease without tremor. So then there's no place for benzhexol.
I think we are behind time, so let's conclude this session. Thank you very much, Professor Thashi, for that excellent talk.